Anishinaabe, how are you? My name is Nancy Young, and I am pleased to present this research project on behalf of Mary Jo Wabino, Diane Jacko, and Marnie Anderson. The project is entitled The Screening Support Successful Early Intervention Among First Nations Children and Youth. I would like to begin by acknowledging that I'm speaking to you from Robinson Huron Treaty Territory, and the land on which I live and work is the traditional territory of the Tikamitching Anishinaabe. This research was conducted in full partnership with Nandawedjagagameg Wikwemkong Health Center. In terms of background, we began by recognizing the strong drive that exists among Indigenous health leaders to promote early intervention and to improve health among their children and youth. Anishinaabe, the Children's Health and Well-Being Measure, is a tablet-based, self-reported health assessment tool. This tool offers Indigenous children and youth a voice in their own health assessment. It also offers community leaders data to inform health planning and advocate for new programs and services. What we know from previous research is that the ACHWM is valid, reliable, sensitive, and specific. The details on the development of the ACHWM and the testing of its measurement properties has been published in a series of open access papers in peer-reviewed journals. These articles are also available on our website. We also understand from our previous research that there are tremendous benefits to communicating with children and youth through technology. Children have found the tablets an easy way to share their experiences. Clinicians have been able to identify key issues quickly and build rapport efficiently. And so what you see here is the questions that the children will answer on the left, and on the right is the way that we present the results back to the children to help them think about their strengths and opportunities to grow other areas of their health. The ACHWM has the potential to support early intervention by identifying the need for health support among Indigenous children and youth in the community. It also has the potential to improve health among this group by connecting those in need of support to local resources, both clinical and non-clinical. This project has 3 research questions. Is the ACHWM able to differentiate between children who need support and those who are healthy? Does it identify needs earlier in children's journeys to wellness? And does screening with this measure lead to improved health outcomes 1 year later? I will now describe the approach we took to answer these questions. Our research methods have also been published in a peer-reviewed journal article. Children and youth between the ages of 8 and 18 were recruited from one First Nation. Each child completed the ACHWM in a variety of locations. They each met with a mental health worker immediately after completing the ACHWM, and this process was repeated 1 year later. 3 groups were created for the purpose of the analysis. Mental health workers assigned the participants to groups based on their professional judgment. The groups were the HP group, which includes healthy peers, who are children recruited in the community who were confirmed to be healthy by the mental health workers. The newly identified needs group were children who were recruited in the community and found to need support by the mental health workers. And the typical treatment group were recruited from within the clinic and were already receiving mental health supports. Our analysis focused on the EQ scores, the emotional quadrant scores, one of 4 quadrant scores within the ACHWM. And we started by comparing the EQ scores for those who were healthy to those who were in need of support. Second part of the analysis took the same EQ scores and compared within those who needed support. So we compared the NIN group, who were recruited in the community and connected to services because of the study and the screening, to those who had entered treatment through the usual mechanisms. The third part of the analysis, we looked at EQ scores and how they changed over time and compared the changes between the 3 groups. I mentioned earlier that this information was published, and here is the article. It's in the International Journal of Indigenous Health in 2018. Our sample included 227 children. 134 of these were in the Healthy Peers group, with 35 newly identified and 58 in the typical treatment group. The sample characteristics are shown here. The groups are fairly similar with respect to age, and there's a slight difference with gender. The Healthy Peers were balanced between boys and girls, but the two clinical groups, the newly identified needs group and the typical treatment group, both included more girls than boys. So what did we discover in working with this group of 227 children and youth? I'm going to show you a series of 3 box plots. There is a legend on this box plot if you wish to pause and have a look at it to orient yourself to the box plots. The middle line on each plot is showing you the median. So half of the people are above and half the people are below. What we saw when we looked at this plot was the Healthy Peers were significantly different from the other 2 groups. But when we looked at the comparison between the NIN and TT group, there was no difference between that specific pairing. So we found that the ACHWM EQ scores were able to differentiate between groups, but not between the NIN and TT groups specifically. Here is another box plot. Again, the EQ scores are shown on the vertical axis and the groups are across the horizontal. What you have here are baseline and follow-up scores approximately 1 year later. You can see that the sample size is smaller because not all participants were followed up at 1 year. However, what we're showing you in the baseline are the matched pairs for the same people we had follow-up for. And you can see that there is no change in the Healthy Peers group. There was no intervention in the Healthy Peers group. We did not expect them to change. So that came out as intended. The newly identified needs group showed a statistically significant improvement, which was one of the key things that we were looking for in this study, is what happened to those children that we identified in the community and connected to services. The typical treatment group also showed statistically significant improvement, as you would expect for children who were actively receiving treatment through the mental health clinic. But the main focus of this analysis was on those 18 children and youth in the newly identified needs group, and what we found was that screening led to improved health 1 year later. This is the same data from the previous slide. It's just shown to you in a different way. On the vertical axis, we have change in EQ scores rather than raw EQ scores. And what you can see is the Healthy Peers change was slightly above 0 with a median of 1. The newly identified needs group had a median change of 11. The typical treatment group had a median change of 7. Local treatment is effective. We also discovered that the NIN group had fewer treatments, and I'm not going to go into detail on that data. Our conclusions were that the ACHWM was able to clearly distinguish those who needed help from those who did not. It facilitated connections to local supports. However, it did not identify needs earlier. Despite this, we found that the ACHWM screening process identified a group of children who demonstrated gains in emotional wellness over time and required less treatment to achieve those gains. This work was supported by funding from the Ontario SPORE Support Unit Impact Grant Program. I'd like to end by saying Chi-miigwech to the children and youth who shared their vision through the project, to the health center leaders who've been the driving force, to the elders for their devotion to the project, to the Health Services Committee and Chief and Council for their support, as well as to the Advisory Committee for their wisdom and guidance.